ready? You got me running.
Before we begin, did you miss me? Like you miss your morning coffee? Like federal workers miss a paycheck right now? Like patients miss telehealth? After 72 straight working healthcare podcast releases, I skipped last week. I'd planned to share audio from the Future of Medicare Advantage panel I moderated at the Coalition of State Rheumatology Organizations National Advocacy Conference in Dallas, but the live recording did not meet our bar. So we're posting the full panel on YouTube with subtitles. You'll hear or read every word from Wendell Potter and Jim Matthews. Why the pause? 7 weeks on the road, 7 talks, 5 conferences, meetings with legislators and members of Congress, coordinating care for my mom, visiting 2 kids with a third this weekend, 1 totaled car, everyone's fine, I wasn't driving, high holy days, contracts, and enough TSA to be on a first name basis. My calendar staged an intervention. I listened to my rational brain, not my monkey brain. Sometimes you have to call it, like the government. As of today, the federal government is shut down, and a central sticking point is whether to extend enhanced Affordable Care Act premium tax credits that were first boosted during COVID and are set to expire at the end of 2025. Roughly 3.8 million more people stay insured if enhanced subsidies continue, but there is a heavy price tag, about $350 billion in federal costs over 10 years is the headline. Marketplace enrollment is at or near record highs, so policy whiplash has immediate effects. Doctors and healthcare leaders are divided on the subject. The ACA system is broken, but does it need to be scrapped or overhauled? Many frontline clinicians demand simpler administrative hurdles, adequate networks, and reliable payments from these plans. Our practice does not participate. This definitely needs to be a topic on an upcoming Working Healthcare podcast episode, and I promise to bring it. So when the government shut down, I shut down, but I did so for only a week. Not quitting, just a sanity pause, so I could bring you better conversations. I'm back, caffeinated, and starting strong. Thanks for the grace. Now let's to it. I am Meredith Hirsh, and this is Working Healthcare. Today, we're pulling back the curtain on one of the most confusing and consequential parts of American healthcare. Why so many legitimate claims get denied, and what that does to patients, clinicians, and the system's bottom line. The numbers are stark. We let insurers reject care in plain sight. On the federal marketplace in 2023, plans denied 19% of in-network claims, nearly 1 in 5. Consumers appealed only about 1% of those denials, and more than half of appeals were still upheld. That's 425 million claims turned into friction in a single year. And here's the gut punch. There is no newer federal data. It's late 2025, and we're still flying blind on what happened in 2024 or the first half of this year. In a system that tracks every patient and prescription, why are we stuck on old numbers? What is being hidden? And by whom? Upstream of denials, prior authorization continues to stall care. In the American Medical Association's 2024 national survey, 94% of physicians said prior auth has a negative impact on patient outcomes, and nearly 1 in 3 reported that it had led to a serious adverse event for a patient in their care. And all this flows into the wallets of real people. KFF and NPR estimate that more than 100 million people, about 41% of adults, are carrying some form of medical debt, with many saying that they never expect to pay it off. Our guest today has made this problem personal and practical. Corey Feldman is the founder and CEO of Protego Health, a New York company that uses AI to help medical billing teams prevent and overturn denied claims. His why started at home. After his brother needed multiple surgeries for colitis, the family was left staring at nearly $1 million in bills. That expense is what fueled Protego, to shield clinicians and patients from avoidable denials and the financial harm they cause. On his podcast, Healthcare Reimagined, Corey has spent years asking leaders how the system really works. Sound familiar? He took what he learned and built a solution. His take? The dollars wrongly denied by health plans each year likely add up to hundreds of billions of dollars, which is why fixing denials is essential to making care affordable. Because you can't fix what you don't understand, we're going inside the payment integrity black box with someone who's lived it and is trying to change it, starting with the human consequences and ending with steps you can take tomorrow. Corey Feldman, welcome to Working Healthcare.
Thank you for having me.
Well, in addition to the government shutdown, we have good news for everybody, and the Israeli hostages were freed, those that are alive, and we're still waiting on those who are no longer alive. But you were in Israel when it happened.
Yeah, it was a pretty comfortable flight on Air Force One. Now, that would have been nice. But I happened to have arrived in Israel the morning of the release, and to say that this country finally, for the first time in 2 years, breathed a collective sigh of relief, I think would be an understatement. It was really remarkable to be here and be part of that. So
that's amazing. What are you doing in Israel? You're an American. You have a New York-based company. What are you doing in Israel right now?
Well, my co-founder, Tal Shulman, is Israeli and actually lives here. So our dev team is based out of Israel. So I am back and forth quite a bit. And in general, I'm a dual citizen. So I'm back and forth when I can be.
That's amazing. So I want to start from the beginning. We could talk about Israel all day long, but I'll leave that to Barry Weiss. So to talk more about Working Healthcare and Protego, you actually went to Penn. So you were at the University of Pennsylvania and you got a degree in political science. How, besides your brother, which I shared a little bit earlier, how did you decide that you even wanted to move into the realm of healthcare?
I really had no sense. I think when I was in university, I knew I would go into the military after college, and political science was somewhat related, I guess, to the science of how and why people fight, is first and foremost how and why nations fight about things. But pretty soon after the military, I went into ad tech, of all things. And a childhood friend of mine, Dave Gelbart, who started a company called Protego Health, now a household name in the DME space, but back then 6 people in a WeWork, called me up and said, if you can learn Portuguese, you can learn healthcare. Come figure this out with me. And I became the 7th employee of Protego Health and the first sales leader, and really just fell in love with healthcare. It felt like, to me, the first opportunity, maybe since the military, to feel part of something that actually mattered. And ad tech was amazing, and Taboola was an incredible company culture, but it doesn't have the same implications for Americans and for people that trying to fix the broken U.S. healthcare system does. So I really just fell in love with the problems. Well, I shouldn't say the problems. I fell in love with the potential to address those problems that Parachute provided, and really just doubled down. So as you noted, I started that podcast, Healthcare Reimagined, sometime around COVID. I became a volunteer EMT during COVID for Central Park Medical Unit, on the front lines of caring for New Yorkers, both those dealing with COVID and a number of other issues that happen in that area, and just really enjoy trying to solve problems that make people's lives better. And of course, this problem in particular affected my own life and my family's life quite significantly when I was in my late teenage years.
You actually started in healthcare sales, and you worked in that realm, which you shared. How did that give you any information as to how the healthcare system was broken?
Well, the rubber meets the road when it's time to pay for things, right? Everyone's interested in things in theory. And in practice, budgets are limited and there are multiple decision makers involved. So I think the process of selling anything is a great life skill because everything is sales, whether it's interpersonal, whether it's business. And the
That is
process
what
of
I say,
learning,
by the way, Corey. I love that because I literally just did a presentation on negotiations. People are like, what do you do all day? I said, I negotiate all day long. And it's similar to sales, right? You're learning the why, you're trying to figure out people's angle, and you're trying to get something accomplished. So I love that. It was the first time I'm like, yeah, sales does bleed into allowing you to uncover the why. So continue. I just wanted to interrupt you. I got excited.
I totally agree with you. You could almost substitute negotiations for sales, but it doesn't necessarily have to be adversarial, right? The best sort of negotiation or the best sort of sale is one that makes both parties better.
Mm-hmm.
And I've been fortunate for the majority of my career to sell things that I genuinely believe in and mostly working for provider facing startups. And so that distance between, oh, this is really cool and I'm willing to pay for it tells you a lot about what actually matters to provider organizations. I would say a lot of my recent education came courtesy of Leverage Health, where I used to work for a guy named Richard Lungin, who really made me study the quarterly earnings calls and the financial reports the payers put out. And people don't know this, but it's not a surprise what's important to them. They say it out loud.
Mm-hmm.
They say the quiet part out loud every quarter. And if you'll just listen to them and you'll read the analysts' comments and questions and watch the major insurers' answers, you start to understand exactly what's important. And that was particularly important to us at Leverage because we represented a portfolio of companies that were selling on a PM basis into those payers. And I think it closed the loop for me, right? Where I understood the patient perspective, spent most of my career selling into providers, and so made an effort to really try to learn how providers see the world. I got a master's in healthcare innovation at Penn. I think it was 2020 was the start of that program. So half my classmates were providers, many of them within the Penn network. And understanding what governs the decision-making apparatus of large health systems and provider groups was one thing, but then the other side of that table, of course, is how do health plans see the world and process information and what is important to them. And working at Leverage, I think, and becoming an investor in HC9, which is the VC that the folks who started it also started, has been really helpful to having a more fuller understanding of how U.S. healthcare works and does not work.
What do you think of VC in the American healthcare system? Is there a right way for venture capitalists to get into American healthcare where they're actually looking for the betterment of healthcare within our population? Or is it still only focused on the net earnings that can be taken out from the system?
Well, a VC, of course, has to pay attention to its investor base, right? Its LPs and GPs, and it has to return the fund, usually multiples of the fund. So the economics matter, but the question of whether or not you can do well and good, I think is absolutely, but you do have to understand the incentive structures. So for instance, the average commercial plan keeps a patient for 2 to 3 years. And so if you are discovering cancer earlier than anyone else ever has, and that's going to drive up the initial cost of someone who might not be with that member when that cancer is discovered. Perversely, it might be a better fit for Europe than it is for the US market. So there are some things that don't make sense at an intuitive level that make sense based on the incentive structures of the US healthcare system. And we can get into it if you want, but I mean, this problem really started in World War II with the Wage Control Act. I mean, that's how we ended up here. But I don't know how down that rabbit hole you want to go.
No, and actually, I've spoken about this on past podcasts of how we got involved in Medicare, how we got the government involved in covering healthcare, and really having these employer-funded plans. And we don't have to dig deep into that because then I don't get into the point of trying to solve the denial issue and focusing on prior authorizations. But the big question is always, we have a lot of VC money. We have PE money coming into the system. And we know that these independent or profit-driven insurance companies like United Health Group, which is ranked number 3 in the Fortune 500, is very focused on really limiting care so they can continue to drive up profits. How is this beneficial for patients? Is this actually the right thing to do for our American healthcare population?
It's an interesting question. And, being in this fund with many ex-payer executives, it becomes harder to write everyone off as evil, right? Which was easy when I didn't know anyone in that world. But the fact is there are many good people and we're all working in a broken system. So what I can say is there are payers out there who look at their costs and understand that by having these offshore call centers and denying claims that they shouldn't, that they ultimately overturn, they end up eating a lot of dollars in the latter half of the year that don't become premiums because their premiums have to be priced in the fall, let's say. So when you think about it from that lens, there are insurance companies out there, and I can call out Alan Murray because he's not at Empire anymore, and he's one of our advisors. And he said, if you could have told me at the beginning of the year exactly what I owed in real time, I would have been thrilled to pay it. Now, I don't know that sentiment is shared across all health plans, but there is a case to be made here for if we were all looking at the same information in real time together, could we make better decisions that helped patients, helped providers, and even helped payers reduce costs that were unnecessary and reduce frustrations? I think the answer is yes. The problem is because of the differing incentive structures and the different data that's available to different parties at different times, we've never really been able to sit at that table together. And so part of the moonshot dream of Protego is to force that conversation and to sit in the middle of those entities and actually be able to have an honest conversation about what gets compensated and why in U.S. healthcare.
But how are you having that honest conversation when really a lot of these insurers are using AI to deny claims that either the patient themselves are submitting or the clinician is submitting?
Yeah. So a lot of these payers will outsource their adjudication engines to like one of 5 big companies. And I agree with you. Those companies do often use AI. We had that case against Cigna that said that doctors were spending 1.7 seconds rejecting medical necessity denials, which are all supposed to be reviewed by a human. So there's no question that games are being played and that there are bad actors here. Like, I'm definitely not on this podcast to defend America's health insurance plans. What I'll say is we are a number of things. First and foremost, a software company, but we got our start, let's say, actually doing billing. So as a full services RCM company serving a single large provider group. And over the course of that work, when we looked back at the denials that our team had gotten, we came to understand that many of them were preventable. So it's not to say that the bar is unnecessarily high for what claims get paid and that the rules are not constantly changing and that there are any number of disparate databases that have to be consulted when figuring out how to code a claim. But if you had access to that information in real time, you could make better decisions and you would check the box for payers, right? And then it becomes a question of, are they going to incorrectly deny those claims?
So what are the reason why claims are denied?
This is a great question. And the fact is, nobody can answer that fully. And let me tell you why. You mentioned that 1% of consumers will appeal, which I think is up, by the way, like 10x in the last couple of years. 2/3 of denials are never appealed across the board, most of which are done by providers. So we also know that at the state level in California and in some other places, will vary, I guess, on these numbers, but 50 to 70% overturn rate, let's say. So what that means really is that the initial denial was incorrect or needed to be restructured and resubmitted. And so if 2/3 of claims are never appealed and the last word on why they were denied is the payers, and the payer's word is often overturned in the form of those appeals, then if we look at the system as a whole, we actually only understand a very small percentage of why claims are denied. And by the way, when you look at the KFF data and whatnot, right, the largest category is always other. Right. So you have 20% coding, 20%, 5% medical necessity. Eligibility is usually one of the biggest ones. And then other, this big opaque other that no one knows what is in that box.
And so we see the others. I know, at least in my clinic, the reason why claims are denied, it's seldom because of an error that we've done, that we don't have, that we're not using the right modifier or some other reason. I'm dealing right now with First Coast Service Options, which is our Medicare administrative contractor, because they actually created an edit in their system in November that is actually an incorrect edit. And I have had to focus on getting backup data from the AMA and from CMS itself, and then going back to First Coast and their sister company, Novitas, who is in Texas and that whole region, like 13 states, doesn't have this incorrect denial or this incorrect edit in the system. And I can't even deny it because it's getting kicked back to me stating that this is incorrect and there is no recourse for appealing the denial. And so I can't even tell you how many hundreds of hours I have spent on this project, along with some of our organizations, to get this overturned or to get this rectified. But I can't even get in touch with the medical director of First Coast right now. And I'm trying to work with it on a national level and a state level. And so that's one example. It's insane. And I don't know anybody else who's fighting it with me because, listen, I know we're coding correctly. So I am willing to stand up and fight for that because that's what I do. But how do you see that you can help either patients or medical practices, because you really help the medical practices fight these denials and get clean claims out, or at least appeal the denial so that they can provide access to patients?
Yeah, I think it's a two-pronged approach, and you're totally right. Things are routinely denied that should not be denied, caused by erroneous edits in the payer clearinghouse or more nefariously within their own systems. And then you're left to, robots issue the denial and people are left to fight them, right? So the first thing we tried to address was that imbalance by creating a system where we could automate the appeal process, could look at the payer, procedure, diagnosis, modifier, et cetera, and use that information to pull all of the policies that are relevant to payment, which might be for a drug, the FDA guidelines. For a routine visit, it might just be the payer's own medical policy, which obviously may vary from payer to payer, and use that information in combination with the medical record to generate a claim level appeal. You denied this for CO55 for medical necessity, but based on these 3 clinical policy bulletins, you define medical necessity for the administration of Stelara as someone who has Crohn's, colitis, or psoriasis. And as you can clearly see in page 2 of the medical record, the patient was diagnosed with moderate Crohn's disease on October the 1st, therefore pay the claim. So there's the question of enforcement, and there's a question of how quickly can you go from receiving that denial to returning an appeal that should justifiably overturn that denial. And I think those are separate questions, the second of which we'll come back to at the end of the episode when you ask me what I would change. But for now, for us, it's about, can we prevent the things up front that can be prevented? And if we've run our checks against those claims, we know that the ones come back in most cases are incorrect. And so we can then use our appeal generator to, on a per claim level, cite the individual payer policies where relevant that justify why that claim should have been paid.
And I like to call them Medicare Disadvantage plans. I have a really difficult time calling them Medicare Advantage, but they're supposed to follow the same guidelines as Medicare, and often they do not. So how are you handling that denial process when you are helping medical practices get something covered?
Well, you're right. They are supposed to follow the same rules, but they are commercial plans getting paid a capitated rate, and it creates all sorts of issues, right? In terms of, are these patients really 7% sicker than the average, Medicare patient, or are we sending clinicians into the house to upcode the sickness levels for higher reimbursements? So there's all sorts of issues.
The Wall Street Journal already proved that. I just want to say the Wall Street Journal already proved that. So yes, they are sending nurses in to recode claims. We're all fully aware of that. So what do we do?
Yeah, it wasn't rhetorical. So they do publish their policies, right? And at the end of the day, there are 2 things here. There's the question of enforcement, and then there's appealing, right? Like at the end of the day, if you are appealing, a lot of times when I see practices before we work with them, and I look back at the old data, I'll see things like you deny this for medical necessity. This was medically necessary. See attached record. And I posit that that's not often being read. If you speak to the folks that are entry level at the payers, you'll understand that they're tasked with processing 60 claims per hour.
Mm-hmm.
That's their metric, right? So they have 60 seconds to run through a claim, and no one's going to punish them for denying it, right? If you incorrectly overturn something, that's going to impact the bottom line of your employer. You better believe you're on the hook for that. So the question is, can we make them look good while getting the practice paid? And that comes down, in my estimation, to providing a succinct and well-documented appeal that cites the reasons why that denial was incorrect in the first place. And that comes down to, again, in my estimation, citing the individual payer's policy back to them as to why it was that you should have been paid for that claim.
How do you get to the right person all of the time? And I ask that because I was just at our National Organization of Rheumatology Management conference, and believe it or not, one of the headliner speakers was a physician who oversaw certain policy and creating hopefully positive change, but I'm not sure about that, with the Blue Cross Blue Shield system of South Carolina. And I literally thought that he was going to be hung on the stage. And at the very end, the moderator or the person who had announced him said, "Hey, you have a few minutes to stay if anybody else has any more questions." And he said, "Actually, I got to get going and get in a car right now." And yeah, probably a good thing that he did, because I still am dealing with Blue Cross Blue Shield South Carolina claims. And I swear they have a dumpster right next to their building that every time medical records are requested, the whoever is delivering those medical records dumps them straight into the trash can. And then I hit timely filing issues. So I, for that specific plan, actually have to send them certified return receipt, which is insane. So how do you actually get the appeal or whatever you're doing, the information that you need to get to the payer? How do you get it in front of the right people?
It's a great question that, frankly, unfortunately, comes down to connections, right? At a certain point,
Oh, connections are king.
People are beholden to their relationships. Healthcare runs on relationships. For purposes of what Protego does, for the most part, we are handing software to provider groups and telling them, "This is Iron Man for your RCM team," right? We're going to put you in a suit that's going to make you 10 times more effective than you were. You still have to fight the fights, but at least now you're well armed to do so. So if before it was taking you 30 to 60 minutes to research a denial and generate an appeal, now you can do it in 2 minutes. And you can spend the other 20 minutes trying to figure out how to get in touch with that person. So you can focus on high value tasks that actually get the job done and get the thing overturned. We do still have some contingency clients where we are using those relationships to get the claims in front of the right people. But for the most part, it's about providing software to provider groups that are doing their own billing, or to RCM companies that enable them to be more effective and efficient in those appeals.
How did you build those relationships with the payers?
I mean, listen, a lot of them came through Leverage Health and HC9, right, as working business development and just selling into those plans, but really just, frankly, developing meaningful friendships, understanding that even though the system fails on so many levels, at their core, most people don't wake up in the morning and say, "Today I'm going to deny a child's cancer payment," right? Like it's not a conscious evil inclination. The results are very much evil, and they very much do lead to these things. But most people genuinely feel like they are in it to make the system better, and they'll point to overprescribing and they'll point to overutilization as driving up healthcare costs as the reason why they need checks like prior auth. And we can respectfully disagree with them, as I think we both do. But we have to understand that the people on the other side of the table don't believe that they're waking up every morning making America worse.
Your brother's experience with the multiple surgeries because of his diagnosis really was the turning point in your life when you realized this is how you could create change in our American healthcare system. If Protego was around during the time when your brother was actually seeking treatment, what would have changed?
Wow. It's a great question. I think we would have had a much better, the policies are so convoluted, right? And the fact is I started this company slightly before OpenAI, and I didn't really know how we were going to do what we ultimately do today. And it kind of fell out of the sky. And it was like, oh, well, here's the answer. We're going to use large language models to make sense of these large, disparate databases and allow people to ask questions about them that they couldn't previously ask. So we probably would have had to raise tens of millions of dollars to do what we've done today on a far lower budget. But if there was an opportunity to actually understand the medical necessity criteria on an individual payer level, there would have been perhaps an opportunity to either file better claims or make a better case as to why those denials were incorrect and overturn them. That didn't really exist back then. If you think about the volume of patients and surgeries that hospitals perform and the fact that most are understaffed, especially in the billing departments, there's just not enough time. And providers really are the first line of defense. Filing those claims correctly and getting the incorrect denials overturned prevents these bills from ever hitting the patient. And so if things go well, the patient never even knows they got a denial, that they get some document in the mail that they don't understand and then call their doctor's office who tells them it went away, we fixed it. That's the dream.
So we have a copay accumulator challenge in multiple states. I don't recall the number of states that have actually created a rule not allowing copay accumulators. I think we're probably up to about 27 right now. So about half of the states. In Florida, we don't have a law enacted. And so we have patients who, once we fight the denial and get the patient approved for the drug, fabulous. But if the pharmaceutical company or if patient assistance is able to help the patient pay the copay and the deductible, which could be thousands of dollars, right? $6,000, maybe even $10,000, depending on the plan, that goes into double dipping and the insurance company keeps it. And the patient is then responsible for that deductible or copay again. Does Protego, or do you know of any solution that can help those people who are faced with this copay accumulator challenge go beyond that hurdle so that they can get the medication that they so desperately need?
I can tell you that I've had Srulik Dvorsky from TaylorMed on my podcast a few times, and they work primarily with health systems, but they work to identify public sources of funding for costly drugs. They started in the cancer space as a result of Srulik's personal experiences. And so that's the name that pops into my head. I'm not sure if that's exactly what they do, but I do know that they help patients and providers get costly drugs that patients desperately need into their hands and solve some of the financial problems that surround that.
Because it seems like that's what Protego is really working on, trying to make sure that the medical care that a patient needs, that a doctor or clinician prescribes, is actually something that the patient can take on, right? And that the patient has access to. So as we move along this path, there are policy changes that happen left and right. I feel like my job is always whack-a-mole and they're forever changing. How do you keep up with all of those policy changes so you know how to appeal these denials?
It's a great question. And I think it's really one of the reasons why what we do now would not have been possible, even 3 years ago. And there were ways perhaps to manually scrub those ever-changing policies and call out, like you would in a Word document, here's what looks different in this one. But there was no real way until the advent of large language models today to insert those changes into the workflow in a way that matters. So when we think about the Copilot, which is our tool that prevents denials, it's not only calling out national coding guidelines, it's calling out individual payer coding guidelines. United might be different from Aetna. And of course, they issue clinical policy bulletin updates every month and tell you all the things that have changed with links to their website. No one has the time to check all of them. And usually the first indication of a problem is when you start to get denied. So what we're able to do with software and with technology is to constantly monitor those at the source, not from the email, but from the clinical policy bulletin itself. We're notified when there's changes. If they are easy changes to make, our software automatically updates. If not, it points a human to the problem and a human goes in and changes our backend accordingly, so that for the practice's perspective, they're using the same tool on Tuesday that they were on Monday. But on Tuesday, the software might make a suggestion that it didn't make on Monday based on a new rule that's been updated.
What's the most common mismatch that you find between the payer policy language and how clinicians document medical necessity day to day in their notes?
It's a hard question to answer in a general sense, but I would say that the medical necessity policies do often state pretty clearly when that combination exists between procedure and diagnosis, because there's also many cases where they're not explicitly mentioning it. But when I'll give you the example of Aetna and Stelara, right? Because that's the one that sticks in my head with my brother's case. Stelara is covered for patients with moderate to severe Crohn's, colitis, and psoriasis, right? And it spells out what that means for each of those conditions. And if you document that the patient has those conditions or those symptoms and that condition, then you meet the medical necessity criteria. So I think it's sometimes the case that the physicians don't state explicitly what's being looked for. And it's actually part of where we're taking the product now, actually, with some of our design partners, is upstream. So as the clinician is documenting, being able to say, hey, doc, this patient has such and such insurance, and it sounds like you're prescribing them with a drug, but I don't see anything on this list of diagnoses that would qualify the patient for that drug. So either think twice or ask the patient about X, Y, and Z to uncover whether or not they actually have one of the things that would qualify them for that drug. So trying to be more assistive in that process to let them know in real time, hey, these are the conditions you need to meet. We're not telling them what to write, right? You either have this or you don't. Don't make up a diagnosis, but just so you know, you can't prescribe that drug for this particular payer unless the patient has one of these 4 conditions.
And sometimes the patient will get approved for the drug, but the drug then must be administered at home. So you have home health and a nurse going out to actually infuse a patient, as opposed to the clinic being able to have eyes on the patient and physicians who are actually within the clinic walls. Sometimes the insurer will say, you know what? We'll send you the medication, and practices are required to white bag. There are many, many reasons that this is not a good option for medical practices, the white bagging, or for patients to have home health administer the drug. Does Protego help in appealing those, denials of buy and bill or being able to infuse in the medical setting?
We got our start in the drug space because we work with a big GI practice, which is, of course, doing a lot of those injections, and they are a buy and bill practice. So a lot of the appeals we were doing in those early days were indeed centered around high cost drugs that were being denied. And it's not just a financial problem, it's a clinical one, because if you're doing buy and bill and you're not able to get reimbursed for those drugs, the clinic is directly losing out, not only on potential revenues, but on literally the money they spent to buy that drug. Mm-hmm. And they'll reach a place at a certain point where they simply can't provide that drug anymore. And the doctor's first choice might have been X, and now they have to prescribe Y. And, we spoke to a number of the big pharmaceutical companies pretty early on, because what they'll do is they'll send a 10-page PDF that says, here are the reasons why this drug should be approved. And it's rather useless, right? It's a long document. It doesn't speak to your specific case. And we told them, listen, we can actually do you one better. We can apply that to the individual case at hand. You can license our software, and now you can actually help these practices make the case for why your particular drug makes sense on a per claim level, not just in a general sense. And each one of them declined because they viewed it as putting their finger on the scale and impacting prescribing decisions, and were afraid of the CMS reimbursement implications of that, even though they all conceded that it would be better than the status quo. So there's a lot of nuances in healthcare and laws that were passed with the best of intentions, whose implications actually lead to, in some cases, worse outcomes for patients and providers. And I think that's one of them.
Yeah, it's very difficult. I hear my doctors all of the time saying, I want to know that my patient is actually getting the right dosage, right? There are weight changes that happen with some patients. And so you have medication loss, right? Wastage more, or you're not infusing the patient on time because you're waiting for the correct dose to be resent. There are so many reasons. I'm thinking of a particular patient that we have right now that we're going through the appeals process with, and he is morbidly obese and he has rheumatoid arthritis, and he's relatively young. He's in his 40s, and the insurance company is requiring him to have home health administer his medication. And that's not really the safest setting. And first of all, if I get it approved, the insurance company is being very difficult on that matter. But once we get it approved, they're like, if we approve it, it will only be approved through home health. And so the doctor loses the ability to coordinate the care and oversight of the patient, and they're giving it to sometimes even an LPN who's infusion certified to actually go into the home when it's a high risk patient. And so there has to be a way to fight these denials. And I'm trying to figure that out. And I'm working with people like you to go through that with this particular patient. But this is just one example. And practices are facing this day in and day out. So what is your percentage of overturned denials that you're actually seeing in real time?
Well, I can't speak to the practices that the data is nascent in terms of the practices
More about
that
what you with
are using our
Protego.
software. Say again?
More with you with Protego. What are you seeing regarding the overturned denials and the rate in which you're able to successfully get the medical necessity covered, or the prior auth, or
Right.
something that's already been done?
For one of the practices, our early client, we have overturned every denial that can be overturned. Meaning these were denials that the practice had given up on and they gave to us. And if it was not past timely filing or didn't fail the MUE edit, right? In some cases, you simply did not meet medical necessity criteria. But in every case where we've been able to overturn those. And I think it's a combination of persistence and maybe a little bit of a vendetta, but it's creativity, right? And I think that's why you're seeing, if I can zoom out a little bit, there was maybe 5 years ago, a big push to offshore RCM and to hire teams offshore. And in a lot of those operations, there's less creativity. It's kind of like, tell me what to do and we'll do it. But that's not the formula for getting past these tricky denials. You really have to be creative. You have to view it as it's like a left brain activity. How do I get around this? What sources of information can I consult, whether they be historic, whether they be individual policies? There's no one size fits all, which is part of the problem, right? Because if there was, then you could automate it. So we can automate a lot of that research and a lot of the appeal generation, but the inputs matter, and individual human creativity matters in this process today, even though it shouldn't.
So what medical specialties do you focus on, and what electronic health records are you a part of right now?
So we have active clients now in OBGYN, dermatology, GI, ophthalmology, and we are actively making inroads into a number of others. But it's not a huge lift to go from specialty to specialty. We obviously learned tremendous amounts in the first couple of weeks with a new specialty, but in essence, the same software that can pull the medical necessity criteria for dermatology claims can do the same thing for ortho claims. So we've moved pretty seamlessly across the specialties. The way we built our preventative tool is to sit alongside any web-based EHR. So we're active with ECW, ModMed, pretty soon with Athena, but we're eyeing a number of different EHRs, Advanced MD, Kipu. So anything that's web-based that can be accessed through a URL, for the most part, we can collaborate with. And then there are other EHRs where they are hard-coded, but maybe the claim isn't touched. And so we've built a way as well for folks to upload their claims prior to submission, and we can return a list of all the ones that have problems and the fixes for those problems. Here are the 40 claims of the 500 that you uploaded that are problematic. This one's missing modifier 25. This one needs a primary first diagnosis, right? So we can actually go through those on a per claim level and return the right answer to the practice to help them avoid that denial.
So quickly walk me through it. You can help clinics on the tail end, but you can also help them at the very beginning by scrubbing their claims. So where do you fit in the whole RCM cycle?
Kind of wherever we're needed. We try to be ninjas in that sense. We saw the writing on the wall with AI was going to be these costly, high promise integrations. And we sought to do something different, which was to try to add value as quickly as possible by tackling an issue that we ourselves had faced when we were doing the billing for that large medical group, which was there are a lot of these denials that touch on coding and medical necessity that all point back to the specific nuances of the way an individual payer processes a claim. And so we brought that technology to bear with a very low lift solution that does not require really any dev resources from the practice at all, and allows us to tag along within their native workflow and call out those problems and challenges. And then, of course, the denials are going to happen, as we've discussed, right? Some fairly and many unfairly. And so the question then becomes, how quickly can you take that denial, understand it, and if necessary and correct to do so, appeal it? And so that's where the second piece of our offering comes in, which is that appeal generator that can either be standalone, or we can integrate through an API to actually pull the data in, or we can integrate directly into the EHR, which we are now piloting with one of the larger EHRs.
What can clinicians and medical practices do right now? What is the one thing that they could do if they're facing an extremely large number of denials, or even just a few denials? What one recommendation would you give?
I think the first is an analysis of like, what are it's the 80-20 rule, right? What are the largest categories of those denials, and what are the reasons? What are the reason codes for those denials? So you have to start with an analysis of why you are getting these problems in the first place. If the number one issue is eligibility, you need a better eligibility checker, right? But if the issue comes down to coding or medical necessity, then you need to contact a company like ours that deals with this stuff and can actually help to prevent those things from happening. The back end AR cleanup is a lot more expensive than it is to prevent them on the front end.
So I'm in rheumatology, and my EHR right now is NextGen. And I say that right now because it has been for many, many years, but I'm very challenged. So you don't work in the rheumatology world right now, and you don't work with NextGen. How do we work together, Corey?
Let's talk about that. Well, there's two things. One is we actually have a signed agreement from a NextGen rheumatology practice, and we have a number that have reached out to us. I am waiting for NextGen to get back to me. So if they're listening to this, I will answer your phone call on the first ring.
I will make sure we connect you. We will connect. Beautiful.
But yes, there are ways around it. As you know, NextGen is a hard-coded EHR, kind of similar to Epic, locally hosted, so it doesn't have the same web-based capabilities. But as mentioned, there's ways to be creative here. So if there's ways to export those claims before you submit them in a spreadsheet even, we can process that spreadsheet, run it against our rules and even custom rules that you tell us that are important to you, and return to you those problems and challenges. We have the appeal generator available in a web-based format, which means it doesn't have to be integrated. So if you have a situation where you want to, through API or even just mass download the progress notes for all your denials and upload them into Protego, we can generate appeals that can be copy and pasted. So is it as efficient as a full integration? No, but will it save you 90% of the time required to research and write an appeal? Yes, arguably still pretty good. So I wouldn't say it's necessarily a barrier. That rheumatology practice does use our appeal generator tool. And the ideal version of this would be working directly with NextGen, and we are definitely open to that.
How do you make money? Because I did interview Waris Bakari, who created Claimable, and his company is paid actually by the patient. You work directly with the practice. So how do you get paid?
So we charge providers a per dollar per month charge in the software licensing module that we've been discussing. There is that edge case of early clients where we're still fighting certain denials on contingency for them. But for the most part, we charge a per provider per month fee. And we tied it to the number of providers because that's how the practice makes its money, based on the number of billing providers. And so if we can help them address the claims for those providers by preventing the denials and more efficiently addressing the appeals, we feel the value comes back to that provider on a per provider level.
So I want to wrap up. And I love the fact that you're creating change within our American healthcare system. I love that you started by studying political science. You didn't know where you were going. You had experience in the healthcare sector, but more on the sales side and when it came to actual devices. And then you had this experience with your brother where you were like, this is not fair. And I just believe in doing the right thing. And I want to create something to provide a better healthcare solution for at least those within our American healthcare system. If you could create one change tomorrow, Corey, I'm going to give you a magic wand, or I'm going to carry my magic wand, because it doesn't have to be something that is actually tangible. I hope that it would be. But what is that one change that you think would solve the challenge, all of the challenges that we have going on right now?
Well, I don't know that it solves all the challenges, but my clients are for the most part independent specialty providers. And so that's kind of who I think about. And I actually met with the former head of CMMI, and the preparation for that, I asked dozens of practices that very question, like, what do you need? What do you want from the government? And I think from her perspective, she wanted to know, what legislation should we pass that we haven't? And my answer was, you're looking in the wrong place. The legislation is there. It's just not enforced, or it's not enforceable within any reasonable timeline, right? You as an individual practice are getting squeezed and you have no recourse. There are laws that are meant to govern the way things are paid for in U.S. healthcare, and those laws are not followed, and the people with the most money win. So if there were a way for practices to more effectively and efficiently enforce the laws that govern the way their payers are supposed to interact with them, I think that would be the magic wand that would force an honest conversation between these two entities. In the absence of that magic wand, you fight force with force, as I think this week showed us, that decades of American leaders seem to have missed, that in the Middle East, the language of progress is the language of the threat of violence. And that, I think, holds true for America's health plans as well, which is if you provide a service that threatens them as an equal, that shows them that you are on equal footing with them and you are able to mass appeal incorrectly denied claims, then you earn the right to force an honest conversation about what gets covered and why. And that is the conversation that we're trying to force in this country.
I love that correlation, and it's so apropos for what is going on in this world. So thank you, Corey.
Thank you for having me on the show.
To everyone listening, the full video of this episode is now on YouTube. Search Working Healthcare and hit subscribe so you don't miss future interviews, short clips, and behind-the-scenes moments. If you've got a question, an episode idea, or someone you think we should feature, you can always connect with me on meredithhirsh.com or reach out to me on LinkedIn, because that's where we keep the conversation going in between episodes. We are also on social media. You can always follow Working Healthcare on Instagram or Facebook. The more voices we bring into the space, the more momentum we build, because change doesn't start with a policy. It starts with a real conversation, like the one today we had with Corey Feldman. New episodes drop every Tuesday. Subscribe and don't miss what's next, because you can't fix U.S. healthcare until you understand how it works. Tune in weekly as we explore the inner workings of healthcare.
You ready? You got me running, got me running.